Littlefield.
I'm Mel Akerman.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G.
Today we're talking about Vasa Praevia. What is it? Why does it matter? And what should we be doing about it? Let's start off with a definition. What is Vasa Praevia?
As with most things in medicine, you can generally work out what the medical terminology means by going back to the word's Latin roots. Vasa is the Latin word for vessel, and previa means going before. So a vasa praevia is a fetal vessel that sits before or in front of the fetal presenting part. The technical definition of a vasa praevia is a fetal vessel running in the free placental membranes within 2 centimetres of the internal os.
Now, it's important to note that the requirement for vessels to be within 2 centimetres of the os is arbitrary and was modelled after the existing definitions for low-lying placentas. There is actually minimal evidence regarding the safe distance that a vasa praevia needs to be from the internal os to be confident that there is no risk of vessel rupture during labour and delivery. Some clinicians have suggested that the definition of vasa praevia should include vessels within 5 centimetres of the internal os because these vessels may also rupture during labour. And in fact, the JOGC in Canada recommends that vessels between 2 and 5 centimetres from the cervical os should actually be classified as low-lying vessels. But in the absence of clear evidence about what the safe distance actually is, the definition of vasa praevia remains at 2 centimetres.
So the reason we worry about vasa praevia is because the fetal vessels are unprotected by Wharton's jelly, which is the usual thick connective tissue that surrounds and protects the vessels in the umbilical cord. As a result, these vessels are prone to rupture in labour or when the membranes rupture. Because the vessels are carrying fetal blood, this can result in fetal exsanguination and death, which can actually occur quite quickly. If undiagnosed, vasa praevia has a fetal mortality rate of up to 60%. Unprotected vessels are also exposed to compression from the fetal presenting part, which can lead to fetal distress and asphyxia. Other complications of vasa praevia include fetal growth restriction and preterm birth.
Vasa praevia occurs in 1 in 2,000 to 1 in 5,000 pregnancies, but rates can be up to 1 in 200 in IVF pregnancies. Factors that increase the likelihood of vasa praevia include a velamentous cord insertion, low-lying placenta, even if it resolves, bilobed placenta or the presence of a succenturiate lobe, assisted reproductive technology, and multiple pregnancy. It's important to note that only about 80% of vasa praevia cases have one or more risk factor.
Now, there are 3 types of vasa praevia. Type 1 vasa praevia is associated with a velamentous cord insertion. Type 2 is associated with a bilobed placenta or succenturiate lobe, and Type 3 vasa praevia is due to one or more large boomerang vessels that run through the membranes along the margin of the placenta without a velamentous cord insertion or succenturiate lobe, and this can occur with things like a resolving placenta praevia. Type 1 vasa praevia accounts for about 90% of cases, whereas Type 2 accounts for about 10%. Type 3 is a relatively newly described entity, and most guidelines only acknowledge the presence of Type 1 and Type 2.
Now, before we go on, can we just explain what a velamentous cord insertion is?
A velamentous cord insertion is where the placental end of the umbilical cord inserts into the fetal membranes instead of directly into the placenta. It occurs in about 1% of singleton pregnancies, but as many as 15% of monochorionic twin pregnancies. Velamentous cord insertions are associated with vasa praevia in 2% of cases and a single umbilical artery in about 12% of cases. Pregnancies with a velamentous cord insertion are at increased risk of vessel rupture leading to fetal exsanguination, vessel kinking or compression leading to CTG abnormalities, asphyxia or death, thrombosis which can lead to infarction and amputation of fetal limbs or digits, fetal growth restriction, stillbirth, and retained placenta. In monochorionic twins, velamentous cord insertion is also associated with discordant fetal growth, FGR, and twin-to-twin transfusion syndrome. There is also some evidence that velamentous cord insertions are associated with an increased risk of pregnancy-induced hypertension and preterm birth.
Suggested management of a pregnancy with a velamentous cord insertion includes, firstly, performing a transvaginal ultrasound at the morphology scan to exclude a vasa praevia. Beyond that, there are no clear guidelines for management of a velamentous cord insertion in Australia. Because of the increased risk of stillbirth and fetal growth restriction, ACOG and ISUOG both recommend serial growth scans to detect fetal growth restriction. There's even a suggestion that women with velamentous cord insertions should have weekly CTGs from 36 weeks in order to detect variable decelerations from kinking or vessel compression. Up-to-date suggests that women should be advised to attend as soon as labour begins, and delivery is recommended by 40 weeks to reduce the risk of oligohydramnios with post-date pregnancies. Reduced amniotic fluid may place the vessels at increased risk of cord compression. CTG is recommended in labour, and caution is required with delivery of the placenta due to the 5.5% risk of requiring a manual removal of placenta.
It is really interesting that we don't have a clear management plan for velamentous cord insertion. Like, maybe, I guess, we just don't have any evidence-based guidelines to follow. Still, I do wonder why velamentous cord insertion isn't part of our FGR screening pathway.
I mean, given the association with stillbirth and growth restriction, it makes sense to me that we should at least be doing fetal growth ultrasound. If any of our listeners have further insight on this topic, please let us know. So we've spoken about velamentous cord insertion and its association with type 1 Vasa Praevia. What about type 2 Vasa Praevia? What's a succenturiate lobe?
A succenturiate lobe is a variation in placental morphology and refers to a smaller accessory placental lobe that is separate to the main disc of the placenta. It occurs in about 2 in 1,000 pregnancies. Pregnancies with a succenturiate lobe are at increased risk of type 2 Vasa Praevia and also postpartum hemorrhage due to retained placental tissue. In a Vasa Praevia associated with a succenturiate lobe, the vessels tend to run in the membranes between the main lobe and the accessory lobe.
And for those interested in Latin, succenturiate comes from the Latin word succenturiae, which means to substitute. Okay, back to Vasa Praevia. How does this actually happen?
The pathogenesis of Vasa Praevia is not really known, but we do have a pretty decent theory about it, and it involves placental trophotropism. Placental trophotropism is where there is dynamic migration of the placenta at its insertion throughout gestation. The placenta tends to grow in areas of good blood supply, like the fundus, and it atrophies in areas with poor blood supply, like the lower segment. Placental trophotropism is the reason why a low-lying placenta noted at the morphology scan may resolve at a later date. The placenta is thought to move at a rate of approximately 1 millimetre per week. Now, the cord insertion is thought to be normal and central at first, but as the placenta migrates, the cord may not be able to keep up, resulting in the cord becoming more peripheral or even into the membranes, like with a velamentous cord insertion. Atrophy of the placenta at its peripheral margins could also explain the type 3 Vasa Praevia. Remember, this is where a portion of the placenta overlying or near the cervix undergoes atrophy, resulting in a boomerang vessel exposed in the membranes adjacent to the placental margin.
I wish I could come up with a little animation for that, because that is really cool. Okay, so how do we diagnose Vasa Praevia?
Typically, Vasa Praevia is diagnosed on transvaginal ultrasound examination. The characteristic ultrasound findings include a linear, sonalucent tubular structure within 2 centimetres of the internal os on 2D imaging. Carla Doppler demonstrates blood flow, confirming that the structure is a vessel. Pulse wave Doppler shows umbilical artery or vein waveforms, confirming the vessel is fetal. Aberrant vessels are attached to the inner perimeter of the fetal membrane, and there might be associations like a low-lying placenta, succenturiate lobe, or a velamentous cord insertion.
Now, it's important to make sure your diagnosis of Vasa Praevia is correct, as there are a few structures that can masquerade as a Vasa Praevia on scan. Differential diagnosis includes motion artifact, cord presentation, marginal placental sinus, amniotic band or chorioamniotic separation, cervicouterine vessels, and cervical varicosities. With a cord presentation, or phunic presentation as it's otherwise known, the vessels are surrounded with Wharton's jelly and can float away from the os if the uterus is shaken or if the patient is placed in the knee, chest, or Trendelenburg position. With cervicouterine vessels, the vessels are maternal, and so flow and heart rate would be consistent with the maternal heart rate rather than the fetal heart rate. Cervical varicosities are frequently seen in placenta praevia. They are typically tortuous, do not pass across the os, and may be part of a venous plexus. Again, pulse wave Doppler would indicate that these vessels are maternal. An amniotic band or chorioamniotic separation can also create the appearance of a sonalucent structure crossing the os. However, Carla Doppler will not demonstrate blood flow, thus excluding the diagnosis of Vasa Praevia.
Interestingly, ultrasound diagnosis of Vasa Praevia has only been around since 1987, So previously, all Vasa Praevias were undiagnosed until delivery. Transvaginal ultrasound with colour Doppler has a 100% sensitivity and a 99.8% specificity for the antenatal diagnosis of Vasa Praevia. Diagnosis is most effective at 18 to 24 weeks and is usually done at the morph scan. It's important to confirm the diagnosis with a repeat ultrasound at 30 to 32 weeks because up to 20% of Vasa Praevias at the morph scan will resolve.
Vasa Praevia may also be diagnosed clinically by palpation of pulsatile vessels in the membranes overlying the cervical os on vaginal examination. Although I'd say this is incredibly rare, if you do happen to palpate vessels, don't rupture the membranes. Clinical diagnosis should also be suspected in the setting of painless vaginal bleeding that occurs with ruptured membranes and is accompanied by a fetal heart rate abnormality such as a sinusoidal pattern, bradycardia, or progressive tachycardia. This is also known as Benkis's hemorrhage. A total fetal blood volume at term is only about 80 to 100 mL per kilo, so even a small amount of blood loss can have a major implication for the fetus and is rapidly fatal.
Now, what's important here is that if you have a suspected undiagnosed Vasa Praevia that ruptures in labour, you should absolutely not stuff around trying to make the diagnosis. Babies can exsanguinate rapidly, and so emergency caesarean section is required in order to provide neonatal resuscitation and transfusion. Historically, alkaline denaturation tests were suggested for confirmation of fetal blood in the event of an antepartum hemorrhage with a normal CTG. However, these tests take time and exsanguination can occur in minutes, so typically there is no time to wait for test results before performing an emergency caesarean for fetal distress. In practice, these tests are impractical and currently have no role in diagnosis or management of antepartum hemorrhage.
I know we don't use these tests clinically, but it is always interesting to learn about them. The alkali denaturation tests include the APT test, the Ogita test, and the Londesloot test. And what do you know about these ones?
The APT test is an alkali denaturation test that is used to differentiate fetal blood from maternal blood. The test was initially developed by Leonard Abt, an American pediatric ophthalmologist, and was originally used to identify the source of bloody stools in newborn infants. It was then modified to distinguish fetal from maternal hemoglobin in blood samples from any source. With the APT test, vaginal blood is mixed with a small amount of sterile water to cause hemolysis of the red blood cells. This results in the release of free hemoglobin. The sample is then centrifuged for 2 minutes and mixed with sodium hydroxide. Fetal hemoglobin is resistant to denaturation by alkali, and so the solution will remain pink. Maternal hemoglobin will oxidize, so the color of the fluid will turn brown. I believe the test is still used in pediatrics today to help determine whether neonatal hematemesis is vomiting of maternal blood or fetal, indicating an upper GI pathology. The Ogita test is similar to the APT test but uses potassium hydroxide instead of sodium hydroxide. Blood is mixed with potassium hydroxide and shaken for 2 minutes. Ammonium sulfate and hydrochloric acid are then added and the mixture is dropped on filter paper with a capillary tube to make a ring of about 2 centimeters in diameter. Denatured adult hemoglobin cells remain in the center, while alkali-resistant fetal hemoglobin forms a colored ring at the periphery within 30 seconds. The Londesloot test also uses potassium hydroxide. You drop a few drops of blood into the tube, add a few drops of maternal blood into another, and again compare the coloring. Maternal blood should turn the solution brown, and a fetal blood should keep the solution pink. You can also use hemoglobin electrophoresis and the Kleihauer test. However, these are both very time-consuming. Now, there has been a study comparing the utility of all of these tests, and the Ogita test was actually shown to be superior. It's simple to perform, doesn't require sophisticated equipment, is unlikely to give false positive results, and only takes a few minutes. Despite that, there's still a bit of a setup required, so it's not used routinely.
I found this really interesting because when I was studying for exams, the APT test seemed to be the only one that was ever quoted, but it actually seems that the Ogita test is the way to go. Sadly, I also couldn't find anything about who created the Ogita and Lundesloot test. Presumably someone named Ogita and somebody named Lundesloot. But it's such a shame. I mean, all this hard work and they don't even get themselves a Wikipedia page.
Maybe we should make one. Okay, back to Vasa Praevia. We mentioned before that the perinatal mortality rate from undiagnosed Vasa Praevia is incredibly high, quoted from 60 to 100%. So I guess this begs the question, should we be routinely screening patients for Vasa Praevia?
Currently, universal screening of singleton pregnancies with transvaginal ultrasound at the morphology scan is not recommended. Arguments against universal screening include firstly that Vasa Praevia is an uncommon condition. At an incidence of 1 in 2,000 to 1 in 5,000, that would mean that thousands of women would have to undergo an unnecessary and invasive transvaginal ultrasound to detect one Vasa Praevia. The second argument is that routine transvaginal ultrasound has not shown to be cost-effective. Instead, targeted screening is recommended. Transvaginal ultrasound is used selectively for screening for Vasa Praevia in pregnancies with risk factors. The presence of a velamentous cord insertion, low-lying placenta, succenturiate lobe, or IVF pregnancy should prompt a transvaginal ultrasound. For all other patients, the placental location and site of cord insertion is routinely examined with transabdominal imaging, and if these are normal and there are no other risk factors for a Vasa Praevia, then a transvaginal ultrasound does not need to be performed. A transabdominal scan of the cervix is also performed with a Carla Doppler to check for any abnormal vessels overlying the os. If there are any suspicious findings, poor visualization, or any findings associated with the Vasa Praevia, then a transvaginal ultrasound is performed to optimize the diagnosis. For those women with a low-lying placenta, we would typically perform a 32-week follow-up scan to check for persistence of the low-lying placenta. Transvaginal ultrasound is indicated at this scan to check for Vasa Praevia, even if the placental location is now normal because of the risk of placental regression leading to Vasa Praevia. Remember, with a low-lying placenta, that placenta can regress over the os and grow towards the fundus, however the cord may not follow suit. This can result in a velamentous cord insertion and a Vasa Praevia, or in a boomerang vessel, like in the newly diagnosed type 3 Vasa Praevia.
Diagnosing Vasa Praevia antenatally is associated with significantly improved perinatal outcomes. Compared with undiagnosed Vasa Praevia, antenatal diagnosis leads to increased infant survival, 97 versus 44%. Increased infant survival without disability, 96.7 versus 28%. Lower rates of neonatal transfusion, 3.4 versus 58.5%. And lower rates of a cord pH less than 7, 0% versus 33%. Antenatal diagnosis also allows us to monitor for other complications of Vasa Praevia, such as fetal growth restriction, preterm birth, and compression of fetal vessels leading to asphyxia. I also just wanted to point out that the AMOS study, Australian Maternity Outcomes Surveillance System, published in 2017, reported 63 women with a Vasa Praevia between 2013 and 2014. 58 of those were diagnosed antenatally, and of those, there were no fetal deaths. For the 5 women that Vasa Praevia was not diagnosed prenatally, there were 2 perinatal deaths with a case fatality rate of 40%.
Okay, so let's get into the management of Vasa Praevia. Our first step in management would be to confirm the diagnosis. Repeating the ultrasound at 32 weeks gestation allows confirmation of the diagnosis of Vasa Praevia and planning for delivery. Serial growth scans are also indicated from 24 weeks, given the association of Vasa Praevia with fetal growth restriction. Bed rest is typically not recommended. However, we do recommend pelvic rest and avoiding high-impact activities. The ultimate management goal is to deliver before rupture of the membranes while minimizing the impact of iatrogenic prematurity. So when and how should these babies be delivered?
Well, Rangscog recommends that we aim for delivery between 34 and 36 weeks gestation in uncomplicated pregnancies with Vasa Praevia. This is partly based off a decision analytic model done by Robinson and Grobman in 2011. This study assessed strategies of scheduled delivery from 32 to 39 weeks gestation and factored in lifetime risks of death, respiratory distress, cerebral palsy, and neurodevelopmental disability. The study found that the preferred timing for delivery is 34 to 35 weeks gestation under most circumstances. Under no clinical circumstances was there a benefit to be gained by expectant management beyond 37 weeks. More recently, a systematic review and meta-analysis by Mitchell et al. Was published in 2022. This study aimed to identify the gestational age at delivery that best balances the risk for prematurity with that of pregnancy prolongation in cases with prenatally diagnosed Vasa Praevia. The study found that prolonging pregnancies until 36 weeks gestation seems to be safe and beneficial in otherwise uncomplicated pregnancies.
Now, obviously, these recommendations are based on uncomplicated pregnancies, and there will always be unscheduled caesarean sections which carry with them a high rate of morbidity and mortality. Earlier emergency caesarean would be indicated in the event of labour or PPROM, abnormal CTG with persistent variable D cells or a non-reactive trace, vaginal bleeding with a fetal tachycardia, sinusoidal heart pattern, or if preterm birth appears imminent.
Clearly, the mode of delivery needs to be a caesarean section. Labour and vaginal birth can result in Vasa Praevia compression, rupture, and fetal exsanguination. Ideally, the hysterotomy should avoid aberrant blood vessels. If a fetal vessel is lacerated inadvertently, the cord should be clamped immediately to prevent fetal or neonatal blood loss. Notify the paediatric team to be prepared for neonatal resus, including possible immediate transfusion with O-negative blood.
When planning for the elective caesarean section, it can be helpful to do transabdominal or transvaginal scanning to map the location of the fetal blood vessels. You should also try to perform a hysterotomy without rupturing the membranes. Once this has been done, you can easily see the fetal vessels and try to avoid them. In some circumstances, people have tried ligating the fetal vessels. However, there's no evidence that this actually makes a difference.
Ranscock also suggests to consider admission and steroid loading from 30 to 32 weeks until delivery, depending on the presence of associated risk factors and proximity to centres where appropriate neonatal facilities allow. The point of hospitalisation is to allow for closer surveillance for signs of labour and a timelier performance of caesarean before labour or membrane rupture. However, the evidence for this is weak. In the 2017 prospective AMOS study, they found that there was no difference in perinatal outcome when Vasa Praevia was diagnosed prenatally between women who were hospitalised compared to those with no antenatal hospitalisation. Overall, outpatient care is associated with excellent outcomes, and so the benefit of hospitalisation in asymptomatic women remains unproven. Outpatient management can be considered for select asymptomatic singleton cases with a long, closed cervix of transvaginal ultrasound and a negative fetal fibronectin. This is supported by a 2013 retrospective cohort study, which reported a 4% risk of preterm emergency delivery in singleton pregnancies diagnosed prenatally. If the patient is admitted, daily CTG should be performed. However, if outpatient management is performed, then the patient should be invited in for twice-weekly CTGs.
I found this recommendation interesting because from my understanding, we're not doing serial transvaginal cervix lengths and fetal fibronectins. Well, not at my hospital anyway. I guess it is an option, but you could probably also consider the cervical length on the previous growth scan, their pre-existing risk factors for preterm birth, and the circumstances around their location and ability to get to the hospital in a timely manner. Just check what your hospital's local policy is on this.
Steroids should also be considered. Now, as we know, ideally steroid loading should be done as close as possible to the planned delivery, and definitely within 7 days. But we also need to be prepared for the possibility of an emergency caesarean section. There's actually no high-quality data to guide timing of steroid administration, fetal surveillance, or the need for hospitalisation. The Green Top guidelines recommend administering steroids from 32 weeks. Up to date recommends steroids at 34 weeks, and Ranscock guidelines don't make a comment on the timing of steroids. Again, discussion with your local team on the timing of steroid administration is recommended.
Once the baby is born, make sure you send the placenta for histopathology. Vasa Praevia is an indication for placental histopathology. Just keep in mind that pathologic examination may reveal a membranous vessel, but the pathologist cannot diagnose Vasa Praevia since they're unable to determine the location of the placenta and the cord in the uterus.
Now, interestingly, there are some hospitals in America offering fetoscopic laser ablation for treatment of type 2 Vasa Praevia. Obviously, this would not be appropriate for type 1 Vasa Praevia with the velamentous cord insertion, but it makes sense that you could ablate the vessels between the main placental lobe and the succenturiate lobe. The idea is that by ablating the vessels, it prevents the risk of exsanguination from ruptured fetal vessels, avoids prolonged hospital stays, and potentially leads to the possibility of a vaginal delivery. The largest cohort study today includes 7 patients treated successfully with this procedure since 2006, with some even going on to have vaginal births. Patients were typically treated at 31 weeks with a procedure time of about 45 minutes. Obviously, the risks of this procedure need to be weighed up against the benefits. In this cohort study, there were no complications, but risks can include anesthetic risks, intraperitoneal amniotic fluid leakage, placental abruption, and chorioamnionitis. Fetal risks include preterm delivery and PPROM, as well as iatrogenic fetal exsanguination secondary to rupture of the Vasa Praevia vessel during laser occlusion. There is also a concern of placental insufficiency if the Vasa Praevia vessels perfuse a substantial amount of placenta. I haven't heard of this procedure being offered in Australia, although I haven't worked at many units offering fetoscopic procedures, to be honest. It does appear to be highly experimental at this stage.
So cool though. Like, fetoscopic surgery is wild. All right, summary time. The definition of Vasa Praevia is a vessel running in the free placental membranes within 2 centimeters of the internal os. The 3 types of Vasa Praevia include type 1, associated with velamentous cord insertion and accounts for 90%. Type 2, associated with succenturiate or accessory lobe, and it accounts for about 10%. Type 3, associated with atrophy of the placenta over the os and presence of boomerang vessels at the placental margin. Complications of Vasa Praevia include vessel rupture with fetal exsanguination, vessel compression causing asphyxia, fetal growth restriction, and preterm birth. Risk factors include velamentous cord insertion, assisted reproductive technology, multiple gestation, succenturiate lobe or bilobed placenta, and placenta previa or a low-lying placenta in the second trimester.
The ultrasound features of Vasa Praevia are a linear sonolucent tubular structure within 2 centimeters of the internal os on 2D imaging. Carla Doppler demonstrating blood flow confirming that the structure is a vessel. Pulse wave Doppler shows an umbilical artery or vein waveform confirming the vein is fetal. Aberrant vessels are attached to the inner perimeter of the fetal membrane, and there might be associated conditions like a low-lying placenta, succenturiate lobe, or a velamentous cord insertion. Universal screening is not recommended. Instead, all patients should have their placental site, cord insertion, and cervix checked at the morphology scan. If there are any concerning features, poor visibility, or risk factors for Vasa Praevia, then a transvaginal ultrasound should be performed.
Management of Vasa Praevia includes confirming the diagnosis at 32 weeks, serial growth scans from 24 weeks, considering admission from 30 weeks gestation, or outpatient management if transvaginal cervical length is long and the fetal fibronectin is negative, considering steroid loading, daily or twice weekly CTGs from 30 weeks gestation, depending on whether the patient's managed as an inpatient or outpatient, an elective caesarean section between 34 to 36 weeks, although evidence shows that closer to 36 weeks is reasonable. With delivery, aim to open the uterus slowly without rupturing the membranes and perform a controlled amniotomy away from the fetal vessels, clamp and cut the cord immediately, and have the pediatric team ready for neonatal resus and neonatal transfusion with O-negative blood. And don't forget to send that placenta for histopathology.
Thanks for listening to this week's episode of the Uterine Sound. We hope you found this episode interesting, and if you have any episode requests, please let us know. Or if you have any placenta previa hysterotomy sites where you've avoided the vessels, please let us know. As usual, you'll find our summary slides on Instagram later in the week. Follow us on socials at The Uterine Sound and check out our website, theuterinesound.com.